I've been invited to talk about how we can kind of align our program outcome or our CNS competencies and show how that work contributes to magnet. So first I have to show you the little study we did, and then I'm going to share with you some thoughts about where we need to go on this. So I apologize for those of you who have seen this before. This has been published in JONA. We actually came out in press last July, a year ago. So now, how do I get this to advance? There we go. Let's see. We know that you guys all know this. But how many of you, are all of you at magnet, just do by process of elimination? Is there anybody here that's not at a magnet facility?
We're technically pathway.
And who's that?
Fishers.
Fishers. But all of you guys, are the rest of you, Ball and everybody's is magnet.
Yes.
Okay, so you're all familiar with, so I don't need to go through this. And when we did our literature review, there was a lot of evidence that CNS contribute a lot to magnet, but there's no real evidence of what those things are and what they look like. So we did a structured crosswalk analysis to really sit down and look at it thoughtfully, and to determine what is the level of alignment between magnet standards and CNS core practice competencies. And crosswalk, if you're not familiar with that, we use them in academics a lot to crosswalk, say, educational standards with what's in our curriculum. So it's a matter of taking information from one to see how it matches with another set of standards or principles or whatever. So we took the magnet standards and we did a crosswalk with the NACNS core competencies. We didn't need IRB. This was simply an exercise on paper. A magnet, as you guys all know better than me, has the 4 components. Now, I know they're coming out with new magnet standards. So this is based on what was present last year. I don't know where they are in the transition, but they have transformational leadership, structural empowerment, exemplary professional practice, and new knowledge, innovation, and improvement. So those 4 components then have 50 what we called standards underneath those. Those are all the little various elements under them. And then they have standards and they have substandards, but their standards are measured through empirical outcomes. And that's what you guys all have to write to for your magnet review. There are 9 transformational leadership, 13 structural empowerment, 21 exemplary professional practice, and 7 new knowledge, innovation, and improvements standards. They don't really call them standards, but they don't really call them anything. So we had to find a word to use for this. So if you look at the magnet document and you look up standards, it may not use this same language, but some of them also had 2 or more substandards, or like only the primary standard was considered. So exemplary practice has a 10A and a 10B. So we just looked at the STEM statement for that. Now, competencies for CNSs, there's 44 in 3 domains, which we call spheres of impact. 16 for direct care, 14 for nursing practice and nurses, and 14 for systems. So we had a 4-member review panel. We had 3 experienced CNSs, 2 faculty, myself and Dr. Walker from Purdue Calumet, and 1 practicing CNS employee at a magnet designated hospital. That'd be you, Tiffany. And a chief nurse executive from a large healthcare system with multiple magnet designations. And guess what his name was? And little did we know when we asked Dr. Gilbert to participate with us that he is also a magnet reviewer. So his understanding of these competencies was in great depth. So first, we all did the exercise. We made up a worksheet. We all did the exercise and went through and saw how we matched. You know, where did a CNS competency match with a magnet statement? And then we had a big meeting on a Saturday morning, because everybody was too busy to do it any other time, where we compared, you know, and we sort of came to consensus on what things were and what they weren't. And it was very helpful to have the administrator's point of view, because we all thought through the clinician's lens or through the educator's lens, and especially with experience in being a magnet reviewer, it's like, no, that's not what we think about that. And we convinced him on a couple of things that he hadn't even thought about. So we kept our notes for that. And then this is what the composite sheet looked like. So these are for this one, for the crosswalk, this is the CNS competencies down here, and here's the magnet standards over here. And then we filled in the blanks where we thought there were matches. And then so you can look here, patient care P1 matches on 2 magnet standards. P2 matches on no magnet standards. So this is how we did our calculation. You get to some things, evaluates the impact of nursing interventions on aggregate patient outcomes. You have 4 matches across the system. So then when we did this forward and backward kind of matching thing, here's what we came up with. If you looked at the magnet standards or magnet components, there was this is just an arithmetic, adding things up and creating percentages. Out of their 9 standards, there's a 55% match with CNS competencies. Structural empowerment, a 92% match. Exemplary practice, 90%. And new knowledge, improvement, and innovation, 100%. So in looking at it that way, there's 86% of the magnet standards overlap with CNS competencies. Now, taking it the other way around, looking at the CNS competencies and looking at their alignment, the 16 competencies for direct care, 62% match, nurses and nursing practice, 100% match, and organizations and systems, 85% match. So that's a total of 81%. So over here we had 86, over here we had 81. That gives you a sense of confidence that we were seeing this, the same thing back and forth. So if you're curious, the top 2 CNS competencies that aligned with magnet were advocates for patient preferences and rights. There were 5 matches in that area, and evaluates impact of nursing interventions on aggregate patient care. There are 4. 6 competencies did not align with magnet standards at all. Assessment, synthesis of finding, prescribing, and teaching, which would make sense because as a direct care provider, the CNS wouldn't necessarily match with magnet here. And then the remaining 8 competencies aligned with at least 1 standard. So 7 competencies aligned with multiple. The 2 that aligned with the most were facilitating professional development opportunities for nurses, students, and other staff, and evaluating outcomes from nursing practice. And the 3 that aligned with at least 5 standards were fostering healthy work environment, employing conflict management, and leading nurses in the change process. Organization sphere, 3 competencies each aligned with 6. Leading, participating in quality improvement, providing leadership for interprofessional teams, pursuing evidence-based practice and research, and evaluating system-level interventions, programs, and outcomes. And 2 CNS competencies in this sphere did not align with any magnet standards, including stewardship of human and financial resources and dissemination of CNS practice and fiscal outcomes. So let me just stop there because I'm running through this really quick. Does that all make sense? Does anybody have any questions about that? You can read all about it in the article if I went flying through it too fast. But I want you to see what we were doing with this matching. So the implications for the nurse administrator, which we wrangled with, has to do with the fact that the CNS role is not where CNSs are employed and organizations are looking to be magnet or on the magnet journey, that really the CNS could contribute a lot towards that work. And administrators are not often aware of this level of support that CNSs can provide, or there are systems that are struggling to get magnet certified and they don't employ CNSs. So there needs to be an awareness of this as a workforce that can help you get to your goal. The other thing is CNS administrators often see, or administrators often see CNSs with the same job title looking completely different depending on where they're working. And I heard you guys say some of you are outcome specialists, and then there are others in ICUs and outpatient clinics. And so how can this be the same job that looks so different? And that's the beauty of our job, but it also is confusing to the world out there. So if you had this kind of a match, and might make it easier to explain, to say the outcome specialist is working on using the competencies to work on these elements of magnet, where the ICU CNS is working on these elements, or it provides support for the depth and breadth of the job. It's not just, well, Joe likes that and Harry likes this and Betty wants to do it her way. It shows that there is a organizing frame behind the differences in our practice, which are all contributing to the same desired outcome for the organization. So that's this last bullet point. It really provides flexibility for the role while anchoring a consistency in performance expectations. And then for infrastructure support for evidence-based practice initiatives and research, the literature shows that that's the most difficult standard for many organizations to meet. So the CNS can be used to leverage a culture of inquiry and close that gap. That's really, we got 100% match on that. And there, unless you have a large organization with perhaps a research nurse and a research department, that smaller organizations have trouble filling this gap. Now for us, and this leads to where we are today, we should align our reports of practice outcomes with the magnet standards. We are experiencing a post-pandemic workforce rebuild, and if hospitals do have magnets, they're definitely going to need some extra props to keep going in these staffing challenged times. And we should embrace leadership roles in magnet, both locally and nationally. All right, so the strong alignment between CNS practice competencies to higher performance of nurse-sensitive patient outcomes reflects, for me, the essence of CNS practice as leaders in advancing nursing practice for improved patient outcomes. That clearly we are aligned with nursing practice. Wouldn't be a good study if we didn't do some limitations. So you have to understand that this crosswalk it's based on the team that we put together. It's limited to what are the standards now. Magnet will change. CNS competencies will change. So, it's human endeavor. But I think that if we could get this in front of nurse administrators, they would be able to see that many times their CNSs are not being utilized to the full scope of what they can do to achieve magnet. And I think that some of these findings can also inform updates for the core practice competencies. So that's the end of that. Any other thoughts on that? Change slide things here. No comments. I was brilliant and explained everything.
Yeah, I think, Jan, it was a fantastic presentation, and this aligns with when we did our last magnet visit. Dr. Deanna Rising looked at the contribution of our magnet document, and 2/3 of our magnet document direct correlation with CNS contribution to the magnet document itself. So this aligns with what we're seeing with our magnet revisit and redesignation.
Yeah. So now I don't know how to. I moved these slides over from that screen to this screen, and now I gotta fix this again. Where did I go to get that?
Right.
Go ahead. Oh,
No, I was going to say, there you go, Jan. I thought you were getting ready to click it. I had a question. It was interesting to me that the transformational leadership portion only aligned with 55% of the CNS competencies. All the others were so high. What's different about that one?
Well, that
is
is
only 55%.
it's a lot about administration and management and staffing and budgeting. And yeah, so it's the administrative infrastructure. Wouldn't you guys agree? Tiffany and Allison were, yeah,
Yeah, that's what I was gonna say, is a lot of it was more operational leadership.
yeah.
Okay.
Yeah, and I guess that they hit that hard on it when they come in and do the review. They want to know how the administrator is engaged. A lot of it comes down to what is the administrator doing to engage with the staff, and what is your staffing, and how do you support the staff for continuing ed, and that's all financial stuff that we don't do at all.
Yeah, I remember having some discussions with Jason on that, because I think this is kind of where you're getting to with that question, Megan. Like, we do feel like we're transformational leaders, and we are leaders in the workplace here. And so it was really hard for me as a CNS to go, oh, that's not what the standards mean from Magnet. It was, to Jan's point, very much about the administration, staffing numbers, those kind of things, not so much about transformational change.
Right. Yeah, so take all that stuff about nursing practice in those two middle competencies, or two other standards where you see the real high match, and there's a lot of leadership embedded in that. Like, we do the clinical leadership. From the Magnet point of view, if they don't have administrative leadership, then everything that they do will collapse. So that they are big on administrative structure has to be in place. And the same thing is true when they do accreditation for programs like CCNE, who does our school accreditation. There's a whole big section in there on administration. Is your dean independent? Can you hire and fire your own people? What are your library resources? Do you have campus facilities? So you could have the world's best syllabus, but if you're trying to deliver that, in a tent on the highway, you're not going to have a very good school. So these accreditation people always look at that. So other thoughts? All right, now where did I go to get that thing to switch screens? Over. I needed to trade me screens again. I'm gonna do that. I'm gonna put that there. Now I'm not sharing my screen, right?
You're still
You are.
sharing. I wonder if you just drag it from.
Well, see if I
Right.
drag it over here. I can drag it over here, but then when I make it big, it goes big on the other screen. So we may have to deal with this. Oh, slideshow. Yeah, it's big on the other screen, not here.
Go to display settings.
There we go.
And
Swap screens.
yep. And if you want to, you can exit out of that other screen on your other screen.
Well,
Does that
doesn't
make
work.
sense?
Apparently not.
Okay. Or I think you can exit out of the presenter mode, or will it totally?
I don't know what I'm doing here.
We can see you're aligning.
Okay, you know what? We're going to go with this. You're just going to have to put up with it. We're at the beginning.
Yeah.
All right. One more time. I know how to do this on Zoom. I just don't know how to do it here. So I'm going to hear you, but I'm not going to see you because I can't get this thing fixed. And slideshow. See that one? Can I minimize that? Oh, there, that worked. All right. Push buttons, eventually something will happen. Okay, so this is what I thought. Oh, when I put a Emeriti on here, for those of you who don't know, I officially retired July 1st. So I have lots of time to make trouble for other things. I think if we want to align our work, we really need to start with the job description. And so these slides I kind of threw together to promote some discussion, but most job descriptions have a position summary, duties and responsibilities, required qualifications, skills and abilities, and then desired. qualifications. And a lot of times there's a lot of boilerplate stuff in there, and they don't actually talk to what does the CNS do in the job. They're kind of, I don't know if you guys have that, but there's a certain amount of boilerplate stuff. So I think that you creating an addendum is a good way to go. That whether it becomes an official part or not, you can do this individually, or you can do this as a group that works in a system or in a hospital. But I like if you were to use an organizing framework like the domains or spheres for our competencies, then take your job description and look at the clinical skills, look at the skills you need for leading and mentoring, and look at your responsibilities for leadership, communication, problem solving, all the system level stuff. And essentially write your job description addendum. And then think about incorporating your magnet. I don't know what if this makes sense as I take this out, but think about incorporating the magnet standards in there. Indicate in the job description the duties and responsibilities that are aligned with magnet. So when you're writing things about, say, patient care or system level stuff, think about here's the competency in patient care competency for any CNS, but it aligns with this magnet standard. So indicate in the job description when you decide to write up what's going to go into patient care competency, it's going to be built off of the CNS competency, but you're also going to put a tagline in it. So you could say behind it, just like we did the crosswalk, behind that expectation for duties in patient care, you tag it as also related to magnet. Does that make sense? Guys, take a look at your work. And I don't know how detailed your job descriptions are. You might have to start with writing this addendum. But I think people need to report out somewhat in alignment with what the organization wants to hear. And they want to hear, are you doing your job? Well, they got a job description that you can't use to report out on, but that doesn't stop you from writing your own. Let me just hear back from you guys. Do most of you have a general boilerplate job description? Or do you have something that's really specific for CNS?
Yeah, I know ours was updated years back, and I don't know exactly what it looks like. I think there were several based on each facility, kind of just writing their own when they were hiring. I know, and then there were different pay codes because of that. So I know that they've gone through and kind of cleaned that up in the last, I don't know, maybe 5 years, was it, Ian? I'm not sure. And so it's more generalized. It's not specific. And there probably is still more than one out there. I just haven't seen it in years. I don't remember what it looks like.
Well, every hospital does a job analysis, and so and that's to pay you. So they need to see that your job is aligned with, I don't know, like clinical pharmacist level 1 or dietitian level 2 or whatever, for standardizing a pay grade throughout the hospital. So you don't want to get into messing with that job description too much, because that anchors you to your pay and benefits. But this addendum idea that I'm talking about is really sitting down and spelling out what it is you're doing. And then, it's a working document, you could call it, not an official document. It would help explain that CNS practice is multifaceted and a great asset to the organization. And you're a go-to person with a useful skill set, but it would also deal with this, what I think is the administrator's dilemma, that the CNS is this elusive employee. And even for managers and administrators who understand what the CNS does in their area, I think if you put them in front of a firing squad and ask them to explain a CNS job, they wouldn't come up with anything. I mean, really, are we giving them the words that we want them to repeat at the boardroom table or in the budget hearings? I'm thinking not, unless somebody wants to challenge me on that. So I say we need to stop complaining, stop explaining, and start reporting. I've been riding this horse about reporting on our work for a long time. We're making progress in trying to figure out how to tag cost savings and revenue generation to our work. But there's a lot of stuff we do that you can't put a dollar sign on. So insofar as that organization's value magnet, start reporting consistent with that. Um, it isn't cheap to get magnets. So if that's a whole big organizational mission, then let's use that to align our work. I think that we have to first identify the work of the CNS. And I think there are ways you can do that. I don't know. I've always thought we should have an app, and then you come out of the patient's room and you hit the app like coding, but we can't build an app until we find the words. Had a detailed discussion with some IT people about building an app. And there's a whole process that goes behind doing that, which is essentially what I've been saying for a long time, finding the words that describe the work. So maybe if you've kept a log, I don't like time stamps for measuring work. And I'll tell you why, because I think our work is like a Russian nesting doll. So you could look at something and it says, well, you're doing a bedside consult for a nurse, but you're also there finding out, if you look at down here, intervening with complex patients. That's what we do, checking equipment for safety concerns. Well, you could be intervening with a complex patient at the same time you're looking at, well, what is this gizmo here by the bedside? And how come this, this doesn't look safe, or the way you've got it set up doesn't look safe. So it's a Russian nesting doll that we do. You don't just say, no, I'm going to do this, and then I'm going to look at the equipment, and then I'm going to, it's too integrated. So just, if you found the words that you could then just make tick marks. I just threw these words down out of something. You'll see where they came from in a minute. But you got to find some key words that represent, and then create a table of your activities, and then use these to work on that job description that you are, or that you're logging, beginning to create a description of what you do. Now, this is from the, I don't know if you guys remember Diane Duran. She invented nurse sensitive outcomes and wrote those books. She was the chief. She's Canadian, and in Canada we have the Surgeon General. In America, they have essentially the chief nurse, or equivalent to, in charge of all nursing in Canada, like our Surgeon General would be here. And this is a 10-year, called a chair. It's a 10-year period, and this was Dr. Duran's work in creating nurse sensitive outcomes. Was what she did during her 10-year appointment as that chief chair for nursing in Canada. And she did this table for us. It's a literature review for the first edition of our CNS textbook. But looking at the literature, this is what she came up with, what CNSs do. Again, these are not put into the domains that we're used to working with the spheres of impact, but they're great words. We do surveillance, we do provision of care, we facilitate groups, we do case management, so if you took these as large groups and then looked at what you did, this is what she found in the literature that she thought belonged under surveillance, but maybe you have other things. So take something like this and begin to build for yourself, or with the CNSs at your hospital, or maybe in if you have 6 ICUs at your place and you got 4 CNSs that cover those 6 ICUs, and maybe you work as a cluster because your work is kind of the same. I don't know. Or across the system, maybe all of the ICU nurses work together, all the peri-op nurses work together, whatever. But start building some terminology, some general categories, and what belongs in there for yourself. This is her, the rest of her. This up here was patient care functions. These are patient education functions. formal and informal. And I know you guys do a lot of this stuff. Certification renewals and precepting students and mentoring nurses at the bedside. So again, this is how she categorized it. There's no right or wrong. I just thought this work had great words to it. In the system sphere, analyzing and synthesizing data, identifying case-related issues requiring remediation. I mean, I think we're onto something here, but this is the way to organize your work. And then there's committees, because every committee, every CNS is on, I could have made 50 S's behind this for committees because, but I think each of you should take a look at committees you're on. Now, I made this stuff up to make this slide, but if you're on a product evaluation committee and you are, why are you there? What do you bring to that committee? And I just encourage you to write it down, because when you write, you begin to recognize what you're thinking. Writing and thinking are so intricately involved, and sometimes you have to write it to understand your thinking. You look at the word, you go, that's not right, it's this. So just do this mental exercise. I don't care if you do it on napkins, toilet paper, graph paper, or on your computer, or wherever you want to, but you need to get the words out. So what are you doing on this committee? Are you there because you're the nursing expert in cardiac ICU and your job is to help select the best products there? And so what kind of outcomes? Are you there and nobody even discussed anything about cardiac equipment? Or what are the outcomes? So you just think about that. So you're answering this question, why am I here? So you can stop saying I'm on a committee, but you can start saying I'm the clinical nurse expert for product selection on this committee. I'm on this committee because I'm collaborating with staff development on designing some strategies to improve staff certification. And I'm actually leading a team that's looking at whatever, a mentoring program or something. And then if you do this and you've got 3 committees that you can't figure out why you're there, well, that's a problem. What are your thoughts? Thoughts. This is why I hate not being able to see you all. This is another tracking table. This is on the toolkit, I think. But when you're given an assignment, do you write that out in real measurable terms? You know, like what is if you're supposed to be in charge of reducing CAUTIs to less than 5% for the surgical patients, and what units those encompass, what are you doing? You know, we tend to say, well, yeah, at the end of the year, we achieved this, but you're doing a lot of stuff to get to that goalpost. So think about your activities there. Are you have a new protocol? Are you doing daily rounds? Are you getting new equipment? What are you doing to achieve this? This is our work, and it's invisible because we're doing it. We're not thinking about it. We're not giving it words. So if you're supposed to reduce the cost of central line dressings with no increase in CLEPSIs because they're buying all these specialized fancy kits, well, are you leading the task force? I really never want to see anybody say I'm on a committee. I want to say you're leading a task force, or you're providing expert input or something, but on a committee is not a job. What's the purpose of who's going to be on this task force? Have you put that group together? Did you order sample kits? Did you find the units that are going to be participating in the trial? Did you develop evaluation criteria? You do this stuff and you don't think about those sometimes as discrete chores, but every one of these things on this little list took up time, probably a lot of time. So here's clinical ladders. You know, again, what units? Did you have a brown bag lunch? How many attended? Did you match people with mentors? Just again, these are just, I put these in here as examples, but if you got that tracking sheet, what you're trying to do is figure out what work you do and what you link it back to in terms of the broad categories of CNS practice or the objectives you're trying to reach. So some point you could take this schmoz of information and say, these are your duties, these are the project objectives, things you're working on, this is your activities, these are your outcomes, and oh my, here's how they contribute to Magnet. So you can not only start at the beginning by linking some of your competencies to Magnet, but you can also, if you're tracking your work, begin to align these. Okay, more people are now certified. CLABSIs are reduced. We have safer equipment in the intensive care unit. We have improved admission processes, whatever. How do those align with Magnet? So. And then you got to report this out. So I just threw this slide in here to talk about the fact that sometimes your reporting has to be multimodal because we have process-oriented communicators and results-oriented communicators. And some of you all work for people who really connect, are relationship-based. They're on a personal level. How's it going? What's happening? Tell me more about that. Oh, well, you know, and then so they want, these people want stories, I think. You got results-oriented people down there that want data. Well, how many? How much? What do you need? Order it now. They approach things in a sort of reserved emotional tone. But you've got people like both of these in the system. So you got to find a way, if you got to figure out who you work for and what they want, but what does their boss want? So you may work for a relationship oriented person who thinks you're great, pats you on the back and gives you great elbow room. I love those people. But you also, then they have to report to somebody who wants data, numbers, percentages. And so you do have to make the charts and the graphs and deal with these kind of folks over here. I'd much rather be chatty about things than talk about a table or a graph. But, you know, we got to deal with both of these folks. So those are my thoughts on how we could do better aligning with Magnet. And I wanted a lot of this to just be about a discussion from you. Am I blowing smoke through my hat? Is this possible? How much work is it? Does it feel overwhelming?
There was a comment in the chat, and when Rebecca had said creating a template Excel document to trial with key work items and drop downs for general topics within preliminary work actions, yet generalizable to all CNS roles. Rebecca, I don't know if you want to speak any more on that. Is that when Jan was talking about being able to track this information in the daily work that you do every day?
While she's thinking about that, how hard would that be for you all to do some tracking?
I don't think it would be difficult. I think what happens though is we are so caught on creating the perfect tracking document that it prevents progress. And after the last CIO CNS conference where we all got into teams and started working on it, our CNS team here in Bloomington really started putting it into work. And I credit Lauren Black, our perinatal CNS, to really push us forward with this. And we started looking at how do we align this with our nursing strategic plan, our promise dashboard, the CNS competencies and the CNS outcomes. But I think the one thing that we don't have in here is aligning with magnet standards. And I think that that's a good point for us to simply add that column and start tracking that. I think our magnet preparers certainly would appreciate it.
Yeah. Well, you know, done is better than perfect. So if you just make that be, you know, your mantra, if you're striving for perfection, it won't happen. So I think you just need to start getting it pulled together in some way. Have you made much progress on that, Vince?
Yeah, we have a separate spreadsheet for each of our CNSs, and we're really populating it and learning from it. You know, you can't have a perfect document, but you can learn from it and adapt it to meet the needs of the organization. And then we have a summary page for, you know, ACNO or the CNO to simply see in a real condensed version of what we've been doing.
Jan, this is Joellen, and I've done this numerous ways since becoming a CNS to being into it for a while. And I think it's really good to, like you said, look at the wording, because you can get bogged down in the day-to-day task time frame commitment that we all have. And I think really synthesizing the words to match the creative thinking and the cognitive work of the CNS is key to getting it to something that is meaningful for our work, that demonstrates to people what we're doing. That's the invisible work. So I think those comments are really helpful.
Yeah, and it will help strengthen the way you think about the work. Yeah, I appreciate that comment, Joellen, because like I said, sometimes you just can't say what you did. When I hear nurses saying we're on committees, well, what did you do on the committee? Why were you there? And well, I had a task force, or you led the evaluation of the product. Use that word. I was the leader of the evaluation team. I designed the evaluation instrument. I put together the objectives for the certification review mentoring program or whatever. You know, try to really be concrete about what you did. And the magnet is full of words. CNS competencies are full of words. Those different references in those different books are full of words. And that's the words that we're doing, but that's not the words that we're using when we describe our work a lot of times.
Laura put something in the chat that I can resonate with, as we have tried at the Academic Health Center to develop a tracking metric and stay on top of it. She said, Vince, likewise, after the last conference, we developed a template that we are utilizing here at Riley. We were steady at its use in the first month or two, but it actually takes more time than we thought to keep it up to date. We need to figure out a process that fits in our workflow so we don't lose track.
Yeah, I've seen at conference before lots of spreadsheets, and I'm thinking the last thing I want to do at the end of the day when my feet hurt, or I got to pick up my kid before daycare throws him out and all that stuff, that I'm going to sit there and go through this enormous spreadsheet. So, you know, I come from the days of the paper Cardex flip thing, if anybody's that old. But you know, you used to just go through those things and make cheat sheets, and we all lived off of the cheat sheet in our pocket because you'd get report and had squares in it. And so you know, make your own cheat sheet for the stuff that you do. And while you're waiting for the elevator, just put a check mark or a note to tag you. You know, this was Mrs. Brown or new nurse on 4 East, or something that reminds you of what you did for that little abbreviated thing. And then at some point you can sit down and put that stuff together. And as you do it, you'll get better at it. So that you can fill that out, but just make your little notes. I mean, you cram that stuff in your pockets all the time. What's the patient's blood pressure and, you know, all those things, and you go back and pull them out. So, and find some time to, even if it's like you got a little stack in your office and you leave them there for the week, but Friday at 2 o'clock is when you always enter your stuff. So again, put it on your calendar. It's important work. We answer the call when somebody pages us, but, and everybody has different work habits. Mine would be to stay late and do it, but there's those of you who come in early and you like to, if you're going to get there at 6 o'clock someday, then from 6 to 7, you just update all your stuff for the week or the month or whatever. You might forget what you're doing, but it's better than nothing. You're capturing 80% of your work or 75% of your work. It doesn't have to be 100%. I saw Rebecca had something in there.
Hey, Jan.
Uh-huh.
So one of the things that we do at Hendricks is that monthly when we have our one-on-ones with our superior, we have a contribution document that's on an Excel spreadsheet. And I put the different spheres of impact. So we have all the spheres of impact: patient, nursing, system, and whatever it was we were working on, we try to categorize into those spheres of impact. But there's also a section where you can have notes, and then we try to do a return on investment, whether it's neutral, saved money, or cost money. But I think it would be also maybe beneficial to have a column that is specific to magnet.
Mm-hmm. I think so.
So I think we have and then what I do is I'll carry my whole section forward to the next month. And if I don't have to report on that thing, it's done, then I just take it off that Excel spreadsheet. But it keeps me organized. But I do think that I might lose some of the minutia that you were talking about, where I need to try to be capturing those moments of interaction and exactly what I did. But I could put that in the notes section.
Well, yeah, whatever works that you've got. And if there's a way to demonstrate how what you're doing is contributing to magnet on a column, I think the beauty of trying to is really about finding the words to explain what you do. And then languaging it in magnet terms. You could just also do the same thing. I think it was Vincent was saying you could language it to the hospital's mission or to the strategic plan or that, but you have to have words like lead, do preventative services. You have to have the right words in there, and we're just not thinking about those things in that way. Physicians have it very easy because their life is all set up in diagnostic codes and equipment coding. So we don't. It's because it's a much more normative practice. Chickenpox is chickenpox. You check this box; it has that code. If you're going to order penicillin, you check that box. Working with a new nurse who doesn't understand a drain or a dressing procedure. Or how to calm down an hysterical relative visitor. Where's the code for that? But that's all the work that we do. So you have to go back to those mentoring and consulting and surveilling and all those kinds of words. So that's why the nurse practitioners have it easier, because they follow the same template for logging their work as physicians do.
This is Joellen again. One thing I do is I just print my daily calendar from my Outlook, and then I take notes on it all day. And if I need to use the back of it, I write it on there. And then I can either save those for the week, or if I want to enter it on my calendar, then I can go back through the month and look at things I've done.
Yeah, good idea. And don't make it harder than it needs to be. Don't start with, I have to have a spreadsheet with drop-down menus. Start with, I need to find the words to describe what I'm doing. And if that's on the back of your calendar, it doesn't matter. What you just need to do is begin to pull them together and write those words that you're looking for to help you find them in your head.
Yeah, I think Rebecca made a good comment in the chat. I don't know if you saw it, Jan, but if you cannot do it weekly, it's too detailed, which I think is good. A good comment. I don't know. I thought that was really good. And then she also said, you know, patient family advocacy could be a new term or something to use as a way.
Yeah. So I agree, Rebecca. If it's too hard, you won't do it. So start with something. It may only be capturing 20% of what you're doing, but if you're doing it, 20% is better than 0. And it will get better over time. And since you guys are all pretty much attached to a magnet place, then at some point where you do your annual report, try to either give numbers of things that you did for bedside mentoring or tell stories, because your audience is a mixed bag and some of them want stories and some of them want numbers.
Yeah, Rebecca, go ahead.
Maybe you have your hand up on your screen.
And Rebecca, you're unmuted, but for some reason we can't hear you. I'm so sorry.
How's this? Is this better?
Yeah, there we go.
Sorry. Yep. Um, if an Excel spreadsheet is done right, and I know you want to keep it simple and just start somewhere like Jan said, but you can do these incredible reports of what the primary pillar was that you were working under or the standard, and then some of your comments associated with that. You can do it as a quarterly if you set it up right, so that on one column is what quarter were you reporting in, but it's important to consider what the spreadsheet should look like in the end once you get a first draft run, so that your reporting is usable for the institution in all these categories. And there's certain ways to set up Excel spreadsheets to get that done.
Yeah, I have used those kind of complicated spreadsheets. I just I have no idea how to design them. I used to do systematic reviews with an international group, and if you check that there was a fatal flaw in the study, then there's a drop down menu just for that box, and you would have to check what it was. Or they wanted to know how many subjects. Well, you check down and you fill in the exact number. How many in the control group? Use a drop down menu and fill in certain things. Yeah, so, and then it aggregates all of that. I could use it, but it was way more complex than I could design. So maybe we need a webinar on designing spreadsheets that work.
IUPUI offers those in their some of their free classes.
I need to take one of those. I have to call my husband every time I try to figure out how to use Excel or build something. He's my Google for Excel. So I think that's a great suggestion for sure.
There's also a platform available through the library there called lynda.com, LYNDA, that has like very short tutorials on anything you need to do.
With Excel?
Yes.
Is this IUPUI, Rebecca?
Yes. Yes.
I'm not sure that all IU employees, IU health employees have access to that. They're two separate systems. You guys at IU Health don't have access to the library, do you? Yeah, so they wouldn't be able to get to I think it's Lydia is the tutorial program, and they wouldn't have access to that. Boo-hoo.
Yeah, I don't either. I only have that as a student access.
Well,
yeah, well, I really appreciate, Jan, did you have anything else, or does anyone else have any other comments or questions?
I hope this was helpful in keeping you guys sort of aligned in our spirit of going forward with looking at our financials that are associated with our work, to also look at how we support Magnet. And I look forward to seeing some manuscripts about how you're figuring all this out.
Well, I really appreciate it. I think it was very helpful, being able to look at it. If it's not always a financial outcome, being able to have that magnet outcome to be able to show that we are producing outcomes and working towards programs that are impacting the organization, as we all are part of magnet organization. So I really appreciate you, Jan, and everyone for coming. For our CEU credits, so you will be receiving a survey from Tanisha Driver. The survey should be open. I'll send it to her today. And so you should get that by the end of the week. I'll send another email and follow up once it has been sent, to ensure if you did not receive it, to check your spam mail or to email me, and we'll make sure you get the evaluation. That'll be done, or you'll have to complete the survey typically by August 1st, 2 weeks following this webinar. If you take the survey and submit that, then you'll be able to get your CE certificate. It'll typically be sent out 7 to 14 days following the presentation. The one thing that I do need to do, and I couldn't figure out how to put a poll on here, is if just to show the interaction with everyone, if you could raise your hand if you feel that you're going to apply this information to your practice or change something about your practice because of this. If you could raise your hand, then I'll be able to track that, and appreciate all of you for coming and being part of this today. And please save the date for our fall conference. It's going to be at the Murat downtown, where we had it last year on Friday, November 3rd. And our theme is lead, empower, advocate, and diversity. We have a great lineup of speakers. The registration will open August 1st. And currently, right now, if you would like to submit an abstract for a poster, please do that on the website. And we hope to be able to showcase some of your great work there. So thank you all for joining, and please don't hesitate to reach out if you need anything or have any questions. Have a wonderful rest of your day.
Thank you so much.